Hi everyone, I want to talk about tumor lysis syndrome. Tumor lysis syndrome. Tumor lysis syndrome is an acute emergency occurring in patients with cancer. For example, in those having Burkitt lymphoma and acute lymphoblastic leukemia. They have just started treatment in most cases, and they will be producing large amounts of potassium, uric acid, and phosphates. And all this will be released into the circulatory system. And that's why I said it is an acute emergency. Imagine when you have high potassium level. If treatment is not instituted on time, there will be a problem with cardiovascular system and the individual could die. It can occur spontaneously, that is, not related to treatment, and is very common where there's high proliferative rate. There's high sensitivity to treatment in some individuals, and that is what will teach them to tumor lysis syndrome. And when there is high tumor burden, we expect tumor lysis syndrome sometimes. It is most of the time secondary to chemotherapy, radiation, or the use of corticosteroids. But like I said, it can occur spontaneously as well. The uric acid that will be produced is from purine in the nucleic acid. The nucleic acid is converted to hypoxanthine and xanthine, and xanthine oxidase is an enzyme that will convert xanthine to uric acid. And that will explain why we use allopurinol, febuxostat, and rasburicase to handle this situation later on. And the excess uric acid produced can lead to uric acid nephropathy. Phosphorus will be very high. It will be as high as multiple of 4 in malignant cases and compared to normal cells. That's what we call tumor degradation, and that will lead to increased phosphate, and when there's tumor degradation, there will be decreased calcium. There will be possible acute kidney injury. Potassium level is closely monitored, and we monitor with EKG and of course laboratory tests to know the level of potassium, phosphorus, and uric acid level, renal function test. I'll go into that in a bit. And when the potassium level is high, we'll treat appropriately. I will not be wasting your time going into details of hyperkalemia or hypokalemia treatment here. I've made separate presentations on each, that is, on hyperkalemia and hypokalemia treatment and clinical presentations. Kindly check out my videos and go into details of hyperkalemia that is applicable here. Still on pathogenesis, there's possibility of xanthine nephropathy, and while I'm going to get xanthine nephropathy because xanthine is expected to be converted to uric acid. Yes, when you use allopurinol, allopurinol prevents xanthine oxidase enzyme from converting xanthine to uric acid. So the presence of allopurinol will lead to excess xanthine that could no longer be converted to uric acid, hence xanthine accumulation that will lead to xanthine nephropathy. Rasburicase is contraindicated in people with G6PD deficiency. Also, there's a separate video on G6PD deficiency. You can check that out. So here with rasburicase, the problem with G6PD deficient people is that uric acid byproduct, that is hydrogen peroxide, will react and lead to hemolysis. So they come down with clinical features of G6PD deficiency. What are the clinical features of tumor lysis syndrome? There's gout arthritis that is understandable with excess uric acid, nausea, vomiting, diarrhea, anorexia. They become weak, particularly if there is problem with the electrolyte potassium and calcium. Sudden death from hypokalemia, yes, sudden death. Hematuria when there's nephropathy and heart failure. Arrhythmia, I've just said it will affect the potassium and calcium. Seizure disorders, muscle cramps, tetany when there is hyperphosphatemia leading to hypocalcemia. So hypocalcemia will lead to tetany and syncope. What are the possible risk factors here? Just going to mention some few malignancies like acute lymphoblastic leukemia, acute myeloid leukemia, chronic myeloid leukemia, non-Hodgkin lymphoma, Hodgkin lymphoma, multiple myeloma, solid tumors, impaired renal functions. Also Burkitt lymphoma, pre-treatment hyperuricemia, because we are dealing with high levels of phosphorus, potassium, uric acid, and low calcium. But even before treatment, the individual is having high level of urea. Then what are we expecting now? Acidic urine, oliguria, dehydration. We have to emphasize dehydration and volume depletion, because when the affected individual is well hydrated and is not volume depleted, then the kidney can help in eliminating the excess produced phosphates, potassium, and uric acid. How do we prevent? We hydrate everyone that is on therapy very well, and we start the hydration even before the onset of the chemotherapy or radiation in any way. If pre-treatment uric acid level is low, we can use allopurinol. But if there is renal failure or heart failure, raspberry case will be appropriate. But remember, raspberry case is contraindicated in G6PD deficient people. How do we make the diagnosis here? Well, it depends on the lab that your center is using, because they have their own normal value range, and depends on the protocol at your center when it comes to potassium, uric acid, phosphorus, and calcium. But that's what we call Cairo-Bishop definition using lab parameters, and that is shown on the screen here. I'm just going to pause a while for you to check that. I'm not going to lay emphasis on it because it depends on what your center will adopt. Raspberry case shortcomings is going to lead to anaphylaxis in some people, methemoglobinemia, false figures while measuring uric acid level is possible. And of course, women of childbearing age should be very careful because of teratogenicity. Febuxostat is newer and of course is better. How are we going to treat here? If there's hyperkalemia, We're going to treat according to the level of the potassium. So check my video on hyperkalemia because I'll not go into the details of that right here. If there is decreased calcium, we first of all treat hyperphosphatemia. Then we replace calcium per aura. If there's hyperuricemia, we treat with verbuzostat. Phosphate binders will be good for hyperphosphatemia. Dialysis is possible if there is severe oliguria, fluid overload, increased potassium, increased phosphate, and calcium phosphate increase. So we can have dialysis here. And with that, I'm going to try to continue right now. Please check some of these videos like G6PD and hyperkalemia that I've produced before so that you get a clearer understanding of how to handle them. Kindly subscribe to my channel, and if you have any question about tumor lysis syndrome, you can drop that at the comment section. Thank you.